Hey everyone, good afternoon. Thank you so much for being here. Welcome back to another episode of Doctors Go Live. I'm Sakina Al-Junaid and I'm sitting in for Nina, who's away today. And then I would also like to excitedly let you all know that you are in for a treat. But it shouldn't sound that way because the topic is actually quite a serious one. Okay, it's about end of life. So what exactly is that? It is called End of Life Care in Advanced Illness. Of course, you're more than welcome to ask questions regarding the topic. And if you share this video out, you get to take part in our Doctors Go Live quiz, where you'll get a chance to win a pulse oximeter. Who doesn't need that these days, right? Of course, it's always good to have an oximeter in the house. Okay, end of life care in advanced illness. Ladies and gentlemen, if you know anyone whose loved one is a terminal patient, or is a terminal patient himself or herself, you may want to share today's Doctors Go Live link so they can join our session with our consultant palliative care physician, Dr. Navin Francis from Columbia Asia Extended Care Hospital, Shah Alam. Yes, death is also a science, okay, and it can be studied, and we've got the expert today with us. But before that, let's take a look at this short video.
Hello there. Do you know someone who's in the last phase of their life? Are you facing uncertainties and difficulties as the end of life approaches? As part of life or illness, many people move into the terminal stage, but not everyone has a comfortable or dignified death. I would like to share with you my experience and knowledge in caring for people at the end of their lives. I'm Navin and I'm a palliative care doctor with Columbia Asia Extended Care Hospital in Shah Alam. Come join me Wednesday, 27 July 2022 for a discussion on end-of-life care in advanced illnesses. See you.
Okay, clearly this is an important subject and could make a difference to someone out there. So don't forget to share this FB link on your social media. Tag your friends and follow us on Columbia Asia social media platforms, because this episode is definitely going to make a lot of difference and a lot of people's lives. Okay, so end of life care in advanced illness. We are addressing a part of life cycle and the inevitable. Yeah, needless to say, it isn't easy for family members or caregivers of terminally ill patients to expect the demise of someone they care about, someone they love. So, ladies and gentlemen, to enlighten us about what we can do to give comfort and care to someone who is at the end of life, let's welcome consultant palliative care physician from Columbia Asia Extended Care Hospital, Shah Alam, Dr. Navin Francis. Hi, Dr. Navin, how are you?
Hi Sakina, good afternoon.
Thank
It's a
you so much
pleasure
for
being
being
here this
here.
afternoon.
I'm sorry, say again?
No, it's a pleasure to be here this afternoon.
It is. Yeah, it's a pleasure to have you, and thank you so much for making time. I know it's a really important topic to address, and we are so thankful that you have actually suggested this particular topic, which we have never done before. So this is a first. Okay, so Doctor, I would just like to remind our audience before we start off. At the end of the show, you absolutely want to enter. It's so obvious that I'm reading. Okay. At the end of the show, you absolutely want to enter our Doctors Go Live quiz, where we've got pulse oximeters up for grabs. And if you have any questions, feel free to ask us in the chat and we will address them right at the end of the session. Okay, and let me see. Wow, look at that. We've not started yet and we already have so many people with us today. Thank you so much, guys. Look at that. Wow. Hello, everyone. Everyone's saying hello to you too. Doc,
Hi.
okay. Yeah, what a very nice and warm welcome. Okay, Doc, first things first, could you share with us a little bit about yourself and what is it that you do as a palliative care expert? What is that?
Sure. Hi. So I've been a doctor for the last 20 years now, and I initially specialized in internal medicine to the master's program in University Malaya. And why that's important is because there is where I learned about palliative care when I was doing a rotation with the palliative team there. I immediately fell in love with that rotation. I loved the work, and I was immediately drawn towards it. I decided then and there, as a trainee in internal medicine, that I wanted to be a palliative physician, and so I steered my path that way. I've been working in the palliative setting for the last 10 years now. Initially as a medical officer, then I became a registrar, and now a palliative specialist. And it's been a joy working in this field. Although it's I'm dealing with a very grim sort of topic for a lot of
Yes.
people. Sad, but I like to believe that palliative care specialists bring a lot of good comfort and guidance to people who are going through this
Yeah.
very difficult period in time.
Yes. Yes.
Has- Right, sorry, carry on.
No, I was just listening to your answer. But doesn't it somewhat affect you emotionally, especially when you lose patients? That's something that
Yes,
you're
I would lie
curious
if I
about.
didn't say, I would be lying if I said it didn't affect me emotionally.
Yeah, yeah,
But as a
right.
doctor, we need to be objective in our work, and the patients, their family are depending on us to make objective decisions in guiding
Right.
them in the in practical manners and how to address this issue.
Yeah.
So I don't say I suppress my emotions. I have empathy for my patients.
Yes,
We
of
work,
course.
we use that empathy, and we act in compassion. And it's I think because we address we accept this part of us, is that we're able to do this work. We palliative
Yeah.
physicians, yeah. So it drives us to do better and to give good care.
Of course, yeah, and someone's got to do it. So, which means that we have this as a science and as a medical discipline, and we're so glad that you are on board Columbia Asia, and I know that you are currently at Columbia Asia Extended Care Hospital in Shah Alam, and also you will be at Columbia Asia Hospital Bukit Rimau. Yeah, as
Yes,
soon
right.
as they launch their oncology center, so that's coming up.
Yes, that's right. I'm actually
Okay,
working there already and working very closely with the
right. I
oncologist
see.
there.
Okay,
And I'm
okay,
very
that's
excited
great.
for the oncology center to be coming up, and I'm sure
Yes.
there will be a lot of people who need my help eventually.
Yeah, yeah.
Um, so
That's
yes,
great.
yes, it's something I'm looking forward to.
Okay, where are you from, doctor? I mean, originally, just curious.
I'm actually a KL guy. Well,
Oh,
mostly
okay.
grew up in Selayang and moved
I
around a bit, but
see.
now I'm based in PJ.
Fantastic. Okay. All right. So great. That's a little bit about you. So let's not waste any more time. We go straight into our topic today, end of life phase. Okay. Today's topic is very intriguing. I'm sure I'm speaking on behalf of our audience. End of life and advanced illness. Could you share with us the importance of recognizing the end of life phase and what is its significance for a patient who is dealing with an advanced illness? Silakan, doctor.
Right. Certainly, the end of life phase is a very important landmark in the patient's journey. It signals key aspects in change of patient's care. At this point, you all the stakeholders involved in a patient's management, care, family members uh, would need to relook at the goals of care, and then we need to redefine those the desired outcomes, shifting the goalposts, so to speak. It also means that it's time to make changes to medication, rationalize that medication, and to relook at treatment choices that may be upcoming in the future, and trying to weed out those that are really not viable to the current goal of care and probably futile in future. It also marks a point in a life in the patient's life where preparation to face this end of life or to face death
Yeah.
begins, and that can mean physically, financially, but also mentally, and also getting the family members, giving them a sort of a heads up. Look, it's time that we start thinking
Mm-hmm.
about
Yeah.
emphasizing quality time together
Yeah.
and looking at what we can do, how we can live life from here on to the fullest.
So
That's
basically,
why.
when we're talking about palliative care, it's not just the patient; it's also family members or loved
Oh,
ones.
certainly,
Yeah.
certainly.
Yeah.
You never have, you know, few things bring people together. One are
Yeah.
weddings, and the
That's
other
right.
are funerals. And it's never just one person. It always affects everyone. Even in an orphan, they don't die alone. They die surrounded with people in a hospital,
Yes.
with friends, with people they know, they worked with colleagues. So it affects a lot of people. It's a lot of emotion there.
Yes. You have to be very strong to be able to face all this. I mean, I'm sure it's the same for all doctors, but especially you because it's palliative care that you are in, right? Okay, doctor, looking at your slide now, when you say change in the goals of care, what do you mean by that exactly? the objective of treatment is different.
Right. Yes. So I have actually a slide, a little bit of an explanation for this later, but let me just tell you that initially, let's take cancer for as an example.
Okay.
Someone is diagnosed with a cancer,
Yep.
and the goal of care is to get to an oncologist, to get to a surgeon, remove the cancer, get chemotherapy or radiotherapy, and the goal of care is cure.
Right.
Now imagine if we've done all that and yet the cancer is aggressive. Are we going to keep harping on curative treatment? I think the oncologist will start to say, look, there, we've got to, consider things in a different light now.
Yeah.
We don't think that curative treatment is going to be helpful any longer here. Maybe we should look into treatment keeps you comfortable, that removes pain, that removes
Yeah.
any distress, and go down that pathway. So that's the change
Yeah.
in the goal.
Okay.
We're not withdrawing treatment. We're not
Yes.
abandoning patient. We are changing the goalpost.
Okay.
We're going to a different
Okay.
direction, but
Yeah.
equally important treatment.
Of course. Yeah.
Yeah.
Okay, let's take a look at the next slide now. End of life equals death is imminent. If we're looking at the timeline of a terminally ill patient, at which point does end of life care apply? Is it upon diagnosis? How would you know when a patient is at an end of life phase?
All right. Now, if you are a very tech savvy person, you'll be scouring the internet, looking at different resources, trying to find out what does end of life or the end of life phase mean. When do we start? Now, I've drawn that little diagram there to show you that in the end of life can be anywhere between 12 months to the few hours just before death. It has got varied meanings for different people.
Okay.
But simply to define it is that it is a point in a patient's care where treatment is no longer curative
Yep.
and we expect that to be imminent. Now,
All right.
how far your position from there on till the end of life, that can be different for different people. And doctors, and nobody can really give you a clear answer for that.
Okay.
Um, but in a sort of like a general way, most of us or most palliative care doctors or people who deal with end of life cases, we
Yep.
tend to take the last 2 weeks to a few hours before that as the general
Right.
meaning for end of life phase. Yeah, so that's
Okay.
what it means.
So before that, we refer to the patients as a terminally ill patient.
Well, labeling them isn't always the best thing to do.
Yeah.
But yes, terminally ill, there's many different words for it, synonyms for it.
Yeah.
Terminally ill, advanced illness, life-limiting illness.
Yeah.
So,
Yeah.
yeah, yeah. So it all really means the same thing. It's just trying to drive the point that we think that this person is not going to live as long as we
Mm.
hoped for or expected in the beginning, and it's
Yes.
time to change gears and start looking
Mm.
at different types of treatment, and that's
Okay.
why it's
So this,
important.
yeah, it's about managing expectations, lah. But of course, nothing is when it comes to life and death. It's not something that anyone can decide. So as you say, this is
Yes,
end
that's
of
right.
death preparation, end of life preparation. Okay, let's take a look at the next slide now. This is regarding end of life is not the same as euthanasia. I think we all know what euthanasia is. Or maybe, doctor, you can just very quickly run through
Sure.
what does euthanasia mean?
So I put up this slide because I do get a lot of questions about this. A lot of people have this misconception of
Yeah.
that end of life care means hastening death. Now,
Yeah.
euthanasia is not palliative care. It's not end of life care. Euthanasia is an act
Correct.
that seeks to death as a way of relieving suffering. Palliative care doesn't do that. Palliative care is we celebrate life. We want people to live well, even though they're facing adversity. Um, Palliative care is about improving quality of life and
Yeah.
alleviating the stress as death approaches,
Yeah.
and it maintains the natural process of dying as an important aspect. We do not want to alter that. We
Yeah.
just want to make it comfortable, and we want to give our patients a dignified death. Time remaining is very precious, and it should be spent with your loved ones, with whatever little you have.
Yeah.
Um, just to give you an idea why we feel that why we feel strongly against euthanasia is that even when someone is unconscious in a coma towards the end of life, science, this actual science has shown that these people can actually recognize, or they can hear sounds that come from their loved ones, so
Yeah.
voices singing, or they have the sensation of touch. It still
Mm.
stimulates brain activity.
Mm.
So there is
Yeah.
an awareness of people at the end of life, even though they can't respond to you, but they know
Yes.
you're there. And I
Even
believe
though
that
there's even though they're sedated.
even though they're sedated,
Oh, okay. All right.
yes,
It's just that they cannot react, but they can hear you.
yes, they certainly can. And that's the very last thing that leaves the patient, their hearing, so they can really hear you
Mm.
until the very end.
Yeah, I see.
And so I believe that this ability to hear and
Mm.
feel your loved one's touch is a
Yeah.
better drug than any medication that we can give them. A better
Okay.
drug for comfort, family bonding, being with your loved ones is a potent
Mm.
potent force for comfort.
Yes, yeah. I'm also looking at our comment section. We've got a few audience who are also commenting while they're watching this. Like Miss Yukong saying it's a hard time for the family members. Definitely, Miss Zura Azu saying we'll are never ready to lose anyone we love, of course, and so we need to spend as much time as we can. Definitely. Okay. Now, next, we're going to be talking about normal pattern of dying. Is there such a thing? Because there's a saying that we've heard: death comes to us all. We've all known family or friends who have passed on because of old age. So, let's say if there is no diseases and there, no accidents. In general, is dying of old age a normal path to death? Sounds philosophical, but
Well,
actually, it's a physical question.
it is
Mm.
philosophical.
Ah,
It's what happens to us. It's the circle of life, isn't it?
yes.
So that has it has a design. It has a natural flow. It is a natural process. It's nothing that we can do to alter that.
Yeah.
This graph that I've put up here tries to illustrate what happens as a person approaches the end of life. The health status is just a way to say that a person's function, the ability to respond, the overall general condition declines over time, and it's in a very gradual decline until they reach death. This is not only in advanced illness. As we get older, as we reach old age,
Yeah.
beyond 100 these days, we will come to it. We will come to our end, and this is how it is. This is the normal process.
Yeah.
Usually and ideally, what happens is that it's a very simple, comfortable, uncomplicated, and slow death or slow decline to death, which gives us allowance for acceptance of what's happening to us. Family can start accepting and cope with this decline and the fact that this person will leave us one day. They will be missed. They will be remembered, but it becomes something that is beautiful and and dignified.
Do they feel pain
And so
every
just yeah, well, that can happen in certain circumstances, and we'll be talking
Mm.
about that a little bit later. But in most people who die have a comfortable death. All that happens really is that they start to eat less, they start to move
Ah,
less, and they start to
okay.
speak less, but they start to sleep more. So it's a very gradual, slow decline that you see over maybe months, or and then later on becomes weeks, and
Yeah.
as the time progresses over days, and then over hours until it just stops. So it's a very gentle way of going, and this is what,
Yeah.
as a palliative care physician, I
Yes.
hope that all my patients will go through. We strive for this, even when
Yeah.
we are faced with very difficult or symptomatic illnesses.
Yeah.
We should
That
think
does
about
actually sound very beautiful. It's like a final farewell, but in a very soothing manner, if you will.
yes, that's right.
Okay. So obviously, people have different experiences at the last phase of life. Is this what we expected to see in advanced illnesses? Or how different can they be?
Okay.
Dying from illnesses, yeah, and dying naturally.
So in this slide, what I want to show you is that research, when we look at the different trajectories of people in the end of life, it's not always that smooth graph I showed you earlier. It's not always that smooth, comfortable way that things happen. And
Yeah.
sometimes the abnormal way trajectories show in four different ways, in four different types of forms.
Yeah.
You have the sudden death, where a person is moving along, functioning normally, and then suddenly collapses and passes away. And you see this in massive heart attacks, big, large strokes, blood clots that get into the blood vessels of the lungs. And there's just really no time to prepare for this. There's a lot of grief,
Accidents also.
accidents, yes, very traumatic
Okay.
accidents, yes.
Yeah.
And it's there's no time to prepare for this, so there's really not
Right.
much of end of life care that you can do here, but
Okay.
bereavement becomes the major role, where psychologists, palliative care physicians, social workers can get involved. Then the second trajectory is the type that we see in these major cancers, where initially they're doing quite well, and they've got good functional status, but once the body's reserves are taken up, then they start on a very rapid decline.
Yeah.
And that's where we have to work a little bit faster to sort of get them comfortable, to ensure that the end of life is uneventful. The
Okay.
third trajectory here is the one at the bottom left of your screen,
The
and
one that goes
that's
up and down.
yeah, that's the organ failure. And organ failure, basically, we're talking about patients who have heart failure, renal failure, liver failure, many other diseases as well. Those are non-cancer illnesses, where there is a overall general decline that people, it's
Yeah.
always going down, but in between you have these really bad declines that go down, where patients they may have an infection, or they may have a
Yes.
sudden exacerbation of their illness. They go really down. There's a false alarm that they're probably going to die. The doctor calls you in and says, "Look, this is the last." This is
Yeah.
the last. And then they recover and go back up again, but it's never back to the baseline. It's never back to what they were before. So, and then they go back to a little worse off phase, and then another episode occurs again. And you see this in patients with heart failure, lung failure, when they come in with fluid in the lungs, and then they go through a whole lot of treatment. Then the doctor
Yeah.
gets them out. And they come back again, maybe in the next couple of months or the next month or
Right.
so. So this is a very burdensome sort of trajectory. It really takes a toll on the patient and on the family as well, because there's really a lot of uh, false alarms to that maybe at the end of life, and then things don't go that way, and sometimes there forms a bit of mistrust. So that's one trajectory that can be quite burdensome. And then the fourth one is when you see in patients who have frailty or dementia. There's a very old patients, and they have very start off with illnesses that cause very poor functional status,
Yeah.
and then they just dwindle, and they go on, and they have a very similar decline to the organ failures, but you don't see that in a very they don't go back to a very high level of functioning after that, and it takes some time for them to pass on. And again, this also is associated with our resources, a requirement for resources, and then it can be a lot of for false alarms as well. So yeah, so these are the four different types of trajectories that we see.
Yeah.
And
The last one,
I have,
the last one, sorry, the last one, this would be more among the older people. I mean, in a very advanced
yes,
age.
generally we see them in the older age group, but you may see that with people who have got genetic diseases, who have got
Yeah.
very poor functional status to begin with,
Yes, yeah.
and that can also be something that affects them as well.
Okay.
There
Uh,
are other conditions that
Sorry.
are special conditions that the end of life trajectory has to be sort of shortened, and becomes really a fast track to getting things done, and that's in special conditions like COVID. And COVID really was a challenge
Yeah.
to get good end of life care to these people. And so I'm sure a lot of people who have lost their loved ones during the COVID time can appreciate this.
Yes.
um, it was a difficult time. Yeah.
Yeah. I just want to share something. This is written by Yvonne Chang. She lost her dad in September 2020. He was very sick for 2 months. They brought him home and had a 24/7 caregiver and also hospice nurse. So she was just suggesting that hospice can help to prepare patients and family. Do you work closely with hospice, or is that something that's connected?
Let me start by saying my condolences to you, Yvonne. I hope you had good care. Yes, I do. I do. We work very closely with the hospices. We have a big network of hospices around, and we also try to work with NGOs and volunteers that help patients at home, charity organizations, and so we try to network. We know that we can't, as a doctor in a hospital, works in a hospital. I
Mm.
know I can't
Yeah.
take care of everything, and a lot of my patients, most patients, want to go home. They want to be at home, they want to be with their family and die. And so
Mm.
we really need the support from hospices who do a great job actually in helping us
Yeah.
manage and look after these patients, guide families at home as well.
Yeah.
Volunteers, before COVID, we had a lot of volunteers, coming in, just
Mm.
helping out. We didn't do not medical stuff, just helping out, and that was gold actually, because that was something that patients wanted.
Mm.
Just sitting down having a chat was something
Yeah.
important
Right.
for them.
Mm.
Yeah.
So you don't have to be formally trained in order for you to help people who are at the end of life stage. What you need is possibly, I suppose, empathy, compassion. What do you say, Doc, to that?
Yes, yes. I think, well, there's many levels of palliative care. Everybody, I
Mm.
don't want you going away thinking that palliative care are only specialists and people who are highly
Yes.
trained. There's a level for
Mm.
that. There is
Yeah.
a tier for that, but there are a lot of people involved in palliative care,
Mm.
and like you rightly said, you need empathy and compassion
Mm.
to provide palliative care. If you read up literature about the work, the network, palliative care network in Kerala, where they
Mm.
use the communities as volunteers to look after terminally ill patients. It's a very beautiful system, and it works so well. It's won awards,
Yeah.
I think, believe. Yeah,
Where is this again? Sorry, is this a movie?
Kerala,
Documentary?
India.
Oh, in Kerala, yeah,
In
in Kerala, India.
Kerala, India. You can
There's
look
a
it up on
documentary
YouTube.
on it.
There's a lot
I
of
see. Okay, got it.
information on YouTube about it. The videos. You can
Okay.
look at videos on live ask that live
Mm.
those videos that look at palliative care and the
Mm.
Asia Pacific Hospice Network
Yeah.
advocating for palliative care in the region. A lot of
That
resources
that is
around. Malaysian
from
hospice,
that is from the state, or are we talking about that's the
just
culture of the
internationally,
community? It's
it's
a health
international. Sorry,
ministry. Sorry,
it's not a health ministry.
is that something that they practice because it's part of the community culture, or is that something that's actually practiced in the government hospitals over there in Kerala?
It's a bit of both, actually. I think it was nurtured by a palliative care physician there, and it was,
Mm,
it was nurtured to be something that the community can be involved in,
mm,
and make an effort to look after their sick and vulnerable. Yeah,
Yeah. In your opinion, does Malaysia have the potential of becoming like that?
certainly. Certainly, our communities, you can see how they band together, even during the floods, how everybody was
Yes,
helping another.
exactly.
And
Very, very true.
even
Yeah.
now, when I have patients who have no family members, who have been abandoned by family, you have neighbors coming in, you have
Yeah,
colleagues coming in and looking
correct.
after them, and I think
Absolutely.
as a group, as people in Malaysia, we've got that culture of caring for one another, and we really want to look out for
Yeah.
each other, and we have empathy and compassion. That's very clearly what we have in this country, and it's encouraging. It's just that in the last couple of years, COVID has really, pushed all the efforts that we've done in
Yeah.
having a good community support, and
Yeah.
we have to isolate people because of the infection risk. So that's
Yeah.
something that we can work again from here on.
Okay.
Right.
Okay. How do we tell who is likely to face problems at the terminal stage? What sort of problems are we addressing here?
All right. So I think it's sometimes difficult to tell when to anticipate problems, and a lot of questions I have is, so what can we expect from here on? What are the issues that can come up. I think the first thing is to identify who will, or who or which kind of patients and what features that they have were predisposed to problems arising in the future. Now,
Right.
cancer is a big issue. It's a big factor because of pain and the effects or the general effects of cancer on the body itself. Cachexia, loss of weight, loss of appetite,
Loss of
pain,
hair.
loss of fat. But that's, yeah, with
Yeah.
chemotherapy and with
Yes,
treatment,
chemo,
it's
of
right.
course.
And then if you have organ failures like kidney failure, heart failure, you're going to have fluids building up in parts of the body that shouldn't have fluids, and that's going to bring about more symptoms and burden. It's going to make people heavy to move about and
Right. Yeah.
and transfer. So you can anticipate what are the problems that can arise from that. If they are bedridden or less mobile, you tend to have more problems as well. You're not functional enough to move about. As humans, we were made to move, and
Yes.
if we don't, we develop symptoms from that.
Correct.
People with poor consciousness often can't protect their airways, can't express that they are in pain or there's something that's triggering them. So
Yeah.
they tend to get into more problems as well, because they don't move. And
Yes.
persons with many coexisting illnesses, diabetes, hypertension, high
Yeah.
cholesterol, uh, arthritis, you know, if these things exist with a cancer or with heart failure, you can expect those things are going to flare up and they're going to cause problems as well. And as palliative care physicians, we deal with all those problems. It's not, let's send you off to somebody else and that we only care for the pain and the
Yeah.
and the cancer and things like that. So this is what we will anticipate, and so when we talk to family members, like, look, this is there, this is what's going to happen, so let's get ready for this. People
Yeah.
with psychological issues prior to having a terminal illness, those with addiction, alcoholism, those facing depression, general anxiety disorder, schizophrenia, psychotic illness, obviously we expect problems to arise from that as well. And we hope not, but yeah, it's always better to be prepared. And social issues, people being abandoned, families being far away from one another, roadblocks in the MCO, separating families, father cancer in Perak, sons in Johor working to support,
Yeah.
keep home in time. You
Yeah.
know, social issues actually can relate, and this is proven by science, can actually lead to physical pain, the sensation of pain. And so
Yeah.
social issues bring about very important problems in at the end of life as well.
Yeah, I think the pandemic was very significant in terms of patients being away from their loved ones, that some of them sadly have passed on among medical people, medical professionals, because they can't be with
Yeah,
their loved ones,
yeah,
vice versa. So that must have been a very tough
yeah.
time for everybody.
It was a very sad time, even for me. I felt quite distressed about it because I used to have patients whom I really wanted their family to be with them at that point
Correct,
in the
yeah.
hospital together with the family, and we just couldn't do it. And yes, we could do this video call, but video call
Yes,
is
that's
nothing
about it.
compared to having physical
Right.
touch.
Yeah.
You're hearing your daughter's or her son's voice beside you, saying prayers. All
Yes.
that was taken away, and I blame COVID. COVID's a monster, really. It really
Yeah.
was very terrifying.
Do you see problems as well? Okay, here we are talking about problems that come from patients, but what about problems from caregivers or loved ones? I mean, what are the sort of things that come from them that could be detrimental to everybody's emotional well-being?
I think the biggest problem I see is family not being with each other. That separation, especially when you know that your loved one is having to go through a tough, a difficult disease, is having
Yep.
so many symptoms, and you just can't be by their side to look after. I think that separation brings about anxiety.
Yeah.
It makes you paranoid about what's happening. Oh my God, he's in pain. He's sitting down there, and nobody's seeing to him. I can't be there with them. Not being able to say their goodbyes. That's the biggest problem there. It's the
Yeah.
emotional, the psychological, the stress that people feel.
Yeah.
the loss of the bond between families that really affects everybody else.
Yeah.
And as healthcare professionals, when we see this, it's
Yeah.
difficult not to draw, you know, not to empathize with them.
Of course. Yeah.
You know, we imagine our families being away from us and not being able to be close. You know, in severe times of stress,
Yeah.
it's difficult. Yeah.
What, in your experience, I mean, so far, I'm sure you've come across a lot in a lot of cases, but what has been, can you cite any particular example of something that you have experienced with a palliative patient that you cannot forget because it was so, poignant, or it was just, not to say memorable, like usually we ask that kind of questions to doctors, but
Right. What
something
affected
that
me the
you
most?
cannot forget, yeah, something that was like really made a mark on yourself as a healthcare professional.
I think I think I have many of the stories.
Yeah.
A lot of them affected me. I can give you a general idea. I don't want to
Okay.
draw specific,
Of
uh,
course, yeah, yeah, right.
but it's always about patients who, at the end of life have difficulty giving up or leaving their families, um, and especially if they're not there in time.
Yeah.
Um, you know, um, I think it becomes difficult when you, as the doctor, who is really a stranger to them, has to sit down by the bedside and hold their hand and just, tell them
Yeah.
that they'll be here, your family will be here, hold on,
Yeah.
and that's not going to really happen.
Yeah.
And it comes to a point where you will have to sedate them, give them medication, put them, get them calm, sleep off, and they may not see their loved ones when they
Yeah.
actually arrive.
Yeah.
um, yeah, so that's a bit difficult on me. Of just so many people are coming to mind right now, but I don't think I want to share that
No, it's,
because
of
it's,
course, of course, yeah. I was just asking for,
yeah,
those
yeah,
examples. But yeah, I get what you mean. That is very tragic. Do you come
yes,
across family who become angry, perhaps, at the situation?
certainly. As I was training, my mentor told me this, and it really hit me hard. He said to me, there is no such thing as a difficult family member.
What
When
is
you
that?
have a patient who is unwell, is sitting down, and you have this family member who comes from somewhere else far
Yeah.
away, they start making all kinds of demands, and then the people that, oh, difficult family member.
Yeah.
But it's not difficult. It's them trying to cope and to see, and to try to accept what's happening to their loved ones.
Yeah.
um, so there's no such thing as difficult family member. I've always, when a family member gets angry and they raise their voice,
Yeah.
it doesn't it just tells me that they are distressed themselves. There's a reason for this. Most of the time there's a perceived sense that proper care was not given to their loved ones.
Yeah.
And it's fine, because I would do it if I felt that my father or my mother or my someone didn't get the right treatment. I
Yes.
would get angry. I would, it's an emotion. It's not something that you can control. I would get angry
Yes.
about it. I think as doctors, and when we are on the other side and we are facing this, we need to have that empathy. We need to realize that it's nothing personal. They want to give the best to them, and they want it. They can't do it. They can't give it. They don't know how. They
Yeah.
expect you to do that for them,
It's very
and
frustrating, I suppose, for them.
it's frustrating. It's just a cry for help.
Helpless.
It's just a
Yeah.
cry for
Right.
help. Please help me help my father, or help,
Yeah.
do something. And it's fine. It's okay. You want to be angry? It's fine. It's nothing. It's nothing personal,
Yeah. So
really.
sometimes you're a shoulder to cry on as well.
Yes,
I'm
yes.
assuming. Yeah. Okay, Doc. What are the symptoms that occur when a person is nearing his or her end of life?
Well, I've put up this this illustration, this slide here, to show
Yeah.
you that this is just the tip of the iceberg of what can happen at the end of life. And I've arranged it in a very haphazard way because I want you to appreciate the chaos that happens at that point of time.
Yeah.
As you can see, I've listed down that pain. Pain's common, but that's not the commonest problem that you get. And you get different types of pain at the end of life. Maybe another day for a full topic on this. This is a 1 day discussion, but you can get pain, you can get breathlessness,
Yeah.
from cancers in the lung. You can get
Right.
breathlessness from fluids in the lung, get
Okay.
secretions building up and gurgling away and choking on your patients. They can have nausea, vomiting. Constipation is a big problem as well, but then with constipation, there's abdominal distension and pain and discomfort, and that can lead to even confusion, which is the most commonest problem that you see at the end of life. This confusion,
Confusion.
uh, delirium, where
Yes.
they just don't seem to be responding to you in the right way, or they have abnormal behavior. Yeah, and sometimes there's hallucinations as well, and that can be frightening, not just for the patient but for the family members.
Yeah.
And then anxiety about what's going to happen, what am I leaving behind, my legacy,
Yeah.
my children, my financial status, the burden that I will left behind. That anxiety can grow on our patient, as well as spiritual distress, losing their place in this world, not knowing the meaning that they have to go through this suffering, why did the cancer come to them. I think I've
Yeah.
had patients tell me, "Doctor, I've been so good. I've
Yeah.
brushed my teeth after every meal. I eat organic food. I exercise. I go to church every day. Not every day, every weekend. Yet, why do I have cancer? Why am I dying? Why did not the chemotherapy work for me?" And there's just no way
Yeah.
to answer that question. But this is the distress that patients have to go. And when you put this all together, and it can come together at one time, it just leads to distress that's just overwhelming and can take over. Yet that the precious moments, you
Yeah.
focus more on the distress than focusing on your family and focusing on
Right.
what's important. Yeah. So these are just some of the symptoms that we have to deal with. The more common ones that are listed here, but some of what more else uh, we can face at the end of life.
Okay. Doc, just very quickly, since we're looking at pain right now, if someone is at the end of life and he is sedated, perhaps, how would we know if he is feeling pain? Because if you're conscious, then body language, perhaps, that's how you can tell that person is undergoing pain. But if you're unconscious, but there is still pain, is there a medical way, like a, I don't know, some kind of detection
Sure.
machine?
No,
Yeah,
no.
because you want that person to be comfortable.
There's no particular special machine that can detect pain. Pain is
Pain, yeah.
subjective. It's very individualistic. It's what the person says it's pain. So we always have to rely on what the patient tells us. But there are some ways that we can tell, some ways that the patient can't control,
Yeah.
or can't hide, even if
Yes.
in the coma. And so we use a tool called FLACC, which just
What's that?
means face, limb, activity, crying, and consolability. It gives us a way of measuring certain body language, body signs, and how they respond, and to come up with a sort of pain score to give us an
Yeah.
idea of how intense pain is. Now, we like to think that patients who have brain injury and show no outward signs of pain are not sensing any pain. We hope that's the case, because with brain injury, hopefully the sensory areas in your brain are sort of knocked off, and
Yeah.
you don't
Yeah.
you don't feel the pain. And if you don't
Right.
feel pain, so you're not in pain really. Well,
Right.
that's a hope, and we hope that's the way it really is. But mostly we depend, in coma patients, we depend on outward signs, which can be there till the very end, and subtle signs, which is where the training comes in. We pick up subtle signs of what
I
could be
see.
distress.
I see.
Yeah.
I see. Okay. It's not difficult then to imagine that the distress will affect more than just the patient. Of course, the family members are also, would be affected. So is that what you're showing us in this next slide?
Yes, that's right. Yeah. So that distress, that it is not just, it's not just concentrated on the patient. It dissipates.
Yeah.
It spreads out to everybody else. You
Yeah,
got
I see.
parents of,
It's not just family members. This is almost everybody
yeah, yeah.
associated.
The
Yeah.
patient's siblings, the patient's parents, the
Correct.
patient's
Yeah.
children, relatives that come from far away, friends who come to
Doctors also,
visit.
nurses.
Yep, yep. So when you're not trained, if you don't know how to handle the end of life phase, doctors and nursing staff feel frustrated. They're doing whatever they can. They're giving the antibiotics, they're giving the drip, they're giving whatever they
Mm,
can, but
mm,
they just can't seem to get the person comfortable. And so those who are not well trained in the management of the end of life tend to get
mm.
frustrated. They feel
Yeah.
helpless. They feel that they are worthless
Yes.
as doctors, as medical
Mm,
healthcare professionals. They're not doing enough. They need to be able to do something to help soothe the patient's distress. And
mm.
so these are the emotions that doesn't affect the patient alone. Everybody around them gets it. You know that the caregiver. I had this patient who in the hospital who they employed a caregiver for just a week to look
Yeah.
after the patient in the
Yeah.
hospital.
Mm,
But when that patient died, this lady, God bless her soul, she cried. She felt something for this patient. She had bonded with the patient, and she cried at the patient's death. And so we sometimes overlook that. We don't think that the nurses, the support staff, feel
mm.
it, but
Yeah.
they're human too. And they do develop a bond with patients even in a short period of time.
Yeah, yeah, I suppose.
So
I
it
mean,
affects
imagine if that patient has been around for an extended amount of time, like patients at Columbia Asia Hospital, Shah Alam,
Yes,
right? Okay, you've got
yes, that's
long-term
right.
patients there.
The longer the time, the longer the bond.
Definitely, yeah.
With all the care that you're giving in, it's you're just like being a family member.
Of course.
Yeah.
Is it harder when it comes to the age of the patient, like when you have a child, who is at the end of life, or do you see a difference in the way the management of palliative care is,
No,
according to you?
I think with children it tends to be a little more difficult with people. I know I struggle with with children having illnesses. But I think different everybody feels differently for at different ages. It really isn't about the age. It's about what they're going through, the experience, and you can really feel really down when someone was an active elderly person,
Yes.
who's bubbly and brought joy, the grandma,
Yeah.
and that person withers away right in front of you. I think it also can be very difficult. I don't think age is really a big factor. Yeah.
Okay. What about the patient's basic needs that can be met by caregivers? Would that be something that's comforting for them? Okay, let's
Well,
see this.
yeah. So with this slide, what I was really trying to say is that when you're in the end of life phase care, the end of life care really depends on a few things. Now, very basic to that is nursing care. We need to have really good nursing care before we
Yep.
can talk about doing other things. And this is not just for patients in the end of life. It's all patients who are bedbound or restricted in movement, who come home or are in a hospital or in a care facility. Nursing care is the backbone to providing good care, and in patients who are terminal, good end of life
Yeah.
care. So it's like I put there, it's basic, it's essential, it's important to provide a comfortable and safe environment to start off with. So the environment that the patient is comfortable, that patient is comfortable in it, and that environment has to be safe in case they become
Yes.
confused. Nothing can harm them in that point, at that
Mm,
place. It's also important that the patient receives regular movement and regular turning. This is
mm,
to avoid contractures of their limbs,
yeah.
to ensure that they don't develop pressure sores, which can be very painful, which can
Yeah.
in turn
Bed sores.
bed sores. That's
Also
right.
felt bed sores. Yeah.
Yes. Something that people often don't take seriously is oral care. Oral care is a very important aspect of nursing
Oh.
care, and end of life care. I had a patient once who was trying to say something to me, and I thought she was speaking to me in a different language, and I
Mm.
just couldn't understand her at all.
Mm.
She was paralyzed, so she couldn't really move and indicate to me. But when we did oral care, we cleaned up the mouth. She
Mm.
spoke beautiful English. As a matter of fact, she was a professor of English,
Oh,
and
wow.
it's just that it was all that muck and dried up mucus in the mouth that obstructed and restricted her tongue
Yeah.
movements, and that's very
Yeah.
important. And that oral care is also very important to avoid infections in the mouth,
Yeah.
to allow and to prevent confusion. Oral care
Mm.
can actually lead to
Oh,
confusion.
I see.
So
Oh,
it's a very
yeah.
important point, and it's something that we
Mm.
check every day, if not twice a day. And there's many ways we can do that, to keep and maintain good oral hygiene.
Yeah. I think not a lot of
Next,
people know about this oral care. I mean, you would know how to change, a patient or move the patient, but oral care, it's something that people overlook. So glad
tend
that
to
you
be
have
neglected.
this here. Yeah.
Yeah. Next is bowel and bladder care. So I guess once a patient stops eating less, they feel like, oh, maybe they don't need to open their bowels, or they don't need
Mm.
to empty the bladders. But that's
Right.
also another important thing. This is something that, if as healthcare professionals, as a caregiver, you need to check on this regularly. Bowel movements shouldn't go more than 3 days. You shouldn't be constipated for more than 3 days. Uh, you need to have regular bowel movements. You need to make sure that the person is passing urine
Mm.
frequently, at least, and to check on whether the bladder is full or not. It's not
Yeah.
retention urine. So these are important aspects of of end of life care, because it
Okay.
affects medication, it affects comfort, it
Mm.
affects the regular normal functioning. And we
Yeah.
know people who are very particular about their bowel movements, and they need
Mm.
it in such a way. It can psychologically affect these patients when they're bedbound, and it is something that they're not comfortable with.
Yeah, of
So this is
course.
another important aspect as well.
Right. Yeah.
Yeah.
Medical
Appropriate
aids. Oh, sorry, appropriate feeding. Yeah.
appropriate feeding. Now,
Mm.
what I meant by appropriate feeding is that towards the end of life, you will find people having difficulty in swallowing, and
Um,
so you may need to change the way we feed patients.
yeah.
But also, we need to also ask ourselves, do they need nutrition? We need to start tailoring nutrition and feeding to what their needs are and what's safe for them. And one thing that happens towards the end of life is people nutrition becomes less and less important.
Mm.
Um, when they're lying down, their caloric requirements are actually very low, and
Mm.
you don't actually need to feed some patients, especially in the end of life period.
Right.
It becomes sort of a mechanism that
Mm.
tells us that the person doesn't require this food, and giving
Yeah.
them or force feeding them just leads to more problems. Um, for instance, fluids. There's a point in time where fluids given, especially to the IV line, don't get
Mm.
absorbed, don't get circulated well, and they start accumulating in under the skin, in the legs or in the hands, and this can also accumulate in the lungs and cause breathlessness. So where
Mm.
you have a patient who did not have any lung disease, developing fluids in the lungs because we just continued to give them a drip, thinking
Right.
that they needed it, and we should force it upon them, and we should give it to them, no matter what the stage is. So what happens is that the lungs start to flood with fluid, and then they have secretions, they become breathless, they have pain, and so this is something actually what medical healthcare has done to them.
Yeah.
So it actually, towards the end of life, a little bit of dehydration is okay. It's sort of a way to help patients soothe their symptoms and to feel comfortable.
Mm.
A food that goes in by a feeding tube may not get absorbed and distends the stomach, and that
Mm.
causes pain, distension, and also impede the
Yeah.
breathing. So this is why I say appropriate feeding, and maybe withdrawal of feeding needs to be
Yeah.
considered, in nursing care. Medical aids, everybody wants to give the best for their family, so medical aids are important, especially if you're taking someone back home, or
Yeah.
if you're in a care facility. these medical aids improve the care of patients tremendously. Having a good medical bed, which has got maybe a motorized or to raise the back or to
Yes.
raise the legs, one with ripple mattress or these air mattresses, which can prevent or help
Yeah.
prevent uh, bed sores and pressure sores. Having a hoist that helps carry the patients, especially patients who are bloated with fluid or heavy,
Yeah.
and move them onto a chair and get them moving about. Oxygen concentrators that help with oxygen flow. Um, the use of a handheld valve blowing air towards the face can help relieve some breathlessness. And many other medical aids, diapers, nutritional supplements, um, and suction machines to bring out secretion, nebulizers to help release secretions. So these are the
Right.
many medical aids that can be useful. But
Yeah.
I think
And
the most of all,
sorry,
the
no,
most
there's a
important of all
comment
in
by.
nursing care,
I'm sorry, I keep interrupting. Say again.
sorry, but I think the most important of all in nursing care for patients at the end of life care is having a dedicated caregiver.
And this
Having
can be a
someone,
family member. It doesn't have to be
it
a
doesn't have to be a family
trained
member.
nurse.
Yes, it can be a trained nurse, but it can be someone who can be trained as well. And
Yes.
it's not that difficult to train people
Yeah.
how
Yeah.
to give proper care at home or in a care facility. And so
Yeah.
these are things that are very basic and very important. And without
Right.
this, I assure you that your patient or your loved one will have a difficult time. Yeah.
In certain cases, doctor, we hear of patients that doctor asked to, okay lah, bawa pulang, bring the patient home because there's nothing more that they can do for the patient. So this
Yeah.
is, I suppose, end of life stage lah. So when the patient is at home, and if you don't have a full-time qualified nurse, and the caregiver is actually a family member, all these things that you have mentioned here in this slide, is this
Mhm.
something that this patient can be trained to do? And where can they get that training from? Is it something that the hospitals will train them first before the patients goes home?
Yes, so it takes time, but when we fast track it to a week, we find that we can actually achieve pretty good care at home as well. We train family members and
Yeah.
caregivers, and certainly, once we plan a discharge, we always invite family members to come in, get your caregiver in. Let's teach them what we can do, what to do, and how to go on, and then we can discharge soon after that, with of course continued support. It's we can't just cut off and say, look, now we've taught you, go ahead, you can do it.
Yes.
No, it's not like that. It has to have We need to have continuous support.
Of course.
IT people support computers, we support end of life care. So it's a process that will be useful if we have a longer time to train someone. But that's
Yeah.
the reality of it, is that we can't afford that. And
Yeah.
so we do our best and we support once they reach home or reach a care
Yeah.
facility.
For
Yeah.
those who can afford it, would you recommend getting a full-time nurse, perhaps?
Certainly, certainly, certainly. I think if you have trained staff, it really cuts a lot of the the uncertainties and doubts that you might have,
Yeah.
and it puts you to rest a bit as a family member, as a caregiver, that someone knows what they're doing, and you're reassured that your loved one is getting the right care. So
Yeah.
yes, it's good to it's we if you can afford it, it's not cheap. If you can afford it, go ahead. I think it's important to do that. Yeah.
Okay. Okay, Doc, I think we've got to just pick the pace up a little bit
Yeah.
because there's actually a lot of questions and a lot of not that many slides to go. Okay, let's just go through. Yeah, what are the most important areas to know when you are dealing with a terminal patient?
All right, so we can move a little bit more quicker with Afyamion, but I think apart from nursing care, equally important in providing end of life care is knowing these two important things. We talked about goals of care earlier.
Yeah.
What are the goalposts? Where are we headed here? So I'll just elaborate a little bit about goals of care.
Okay.
So when we're dealing with a disease that's potentially curable, our goal of care is cure, get back to life, get back to work, get back to living.
All
But
right.
when you don't have that, So what is the next best thing when cure is no longer possible? So you
Yeah.
want to get to a point where, okay, I want a life which is comfortable. I want good quality of life, and I want
Yeah.
to be spent with my family. Okay, so that's doable. In that process, what are your preferences?
Mm.
So what would you not want done to you medically? Because as doctors, we know what to do. We have got a whole arsenal of things that we can do, put on you.
Right. Yes, of
We
course.
can stick you with needles. We can put a tube down your throat. We can put you onto a
Mm.
ventilator, and we
Mm.
can keep you on medication that keeps your heart pumping away.
Mm.
And when your heart stops, we'll jump on you and we'll do CPR,
Yeah.
and do a whole lot of things until it all doesn't work.
Right. Yeah. Yeah.
But would you want that? Would you want to go through all that? So that comes to the next point, your preferences. So it's important to know the
Mm.
person's preferences. And ideally, we want to know these things way before the end of life, way before the end of life phase. It's something that needs to
Mm.
be planned much earlier and preferably put into an advanced care plan so
Mm.
that everyone knows, even the doctors,
Mm.
caregivers, other family members, extended family members, people know this is what was planned, this is what they want, this is how they want a dignified death.
Oh, I see. But where can at which point and where can this be created? This advanced care plan, because this
Well,
is a bit.
in Malaysia,
Mm.
we don't have legislatures or laws
Mm.
on mandating advanced care plans, but many
Mm.
hospitals, many doctors advocate it. Palliative care doctors certainly will help you plan this. It's not
It's not
it's not a,
euthanasia, right?
oh, no. This is
Yeah,
just your
yeah.
preference there. Yes, it's just your preference.
Yes,
What you don't
it's not
want.
to fasten. Yeah, okay.
Yeah.
All right.
Treatment given to someone must be
Mm.
consented for. If a person doesn't consent to treatment,
Mm.
we should not administer it. So these are the preferences that I'm talking about in an advanced care plan. You put down, no, I don't want CPR, I don't
Mm.
want to be ventilated, I know
Mm.
where I'm heading. I know that there's no chance for me to survive this. But I
Mm.
want a
Mm.
comfortable death. That's my goal of care. I want a comfortable death. I don't want any blood taking. I don't want any needles stuck into me. I want to be
Mm.
given medication that keeps me comfortable, and I want to have a smooth, dignified,
Yeah.
comfortable death. This is my goal of
Patients,
care.
patients in Malaysia are allowed to refuse some of the things that you mentioned just now?
Certainly, anywhere in the world, you're allowed to
Oh,
refuse any
okay.
treatment.
I
A
see.
doctor
I
can't
see.
touch
Okay.
you.
I thought
Can't
as
touch
long
you
as
without consent.
I see if it's I thought if it's the doctor that recommends something and then they just have to go with it. So I suppose that's why you've got a form, to say that yes, you consent. The consent form, that's what it's for.
Well, that's why we're called consultants. We
Yeah.
give you a
Correct.
recommendation.
Yes,
We
yes.
tell you the pros and the
Literal.
cons. And if we don't do that, we're not doing our job. So, you need to have you have a clear idea of what it is that we are doing.
Okay, Doc. We're going to take some questions now. Okay, the first question is from. Hold on, let's just take a look at quite a few.
Are we
Zura
back?
Azul. Yeah. Can the terminal stage patient just eat what they want as they wish because they don't have good appetite to eat, food like healthy people do? Can we allow that? Oh, I see. Okay.
Right.
Right.
Zura, thank you for that question. I want to say yes, but there are
Mm,
some little caveats to that. Now, if you have a cancer patient and you don't have much to live, you
mm,
know, I don't see a point in restricting food, giving them the oral pleasure of tasting the food that they want. But you got to also
mm,
keep in mind that some food, especially like in patients who have fluids in their lungs, heart
mm,
failure, liver failure, kidney patients, if they have excessive fluids, if they have food that gives them a high salt food, that can bring
mm.
about immediate problems. That can bring about immediate deterioration, decline in their health. And so
Yeah.
you want to avoid food that can cause immediate harms, and you want to choose food that can give them the pleasure. Personally, I wouldn't really, I don't have a blanket restriction on food.
Mm, mm, yeah.
Forget the diabetic diet, forget the,
Yes.
that special low calorie, sorry,
Mm,
low cholesterol
yeah.
diet, you know. But you got to look
Yeah.
at it. to make sure that the food itself does not cause harm and does not get
Yeah,
the
you need to be
patient
smart about it. Lah.
to the hospital.
Yeah.
Yeah.
Can they do exercises? I mean, maybe they're not feeling well or they're just not comfortable. Is that something that you would recommend?
Certainly,
Because they're not
certainly.
feeling well and feel nausea when they're standing or walking. It's also from Zura Azu.
Sure. Um, Exercise is very, very important, not just at the end of life, from the beginning itself, and we should not stop. I think a lot of our illnesses now are because of the lack of exercise, but maintaining muscle strength, maintaining mobility is good, is important in maintaining function. It helps patients tolerate treatment, tolerate symptoms better, and
Yeah.
it helps to build endurance in patients. So exercise are important even when they are bed bound. Light physiotherapy on the bed is very important in preventing pain and and pressure sores, so complications at the end of life. So yes, exercise is important. It's extremely important.
Okay, let's take a question now from Yu Kyong. And the question is, how do you educate and expose death and dying of the loved ones to the kids? How do you break the news to children?
So a lot of us feel that we need to protect children from death.
Yeah.
A lot of times, in my experience especially, I feel the children already know, and they may not really know how to react to it. um, I think being gentle in the words that you use, but not being very vague itself,
Mm,
helps breaking news to children. You've got to sit down and talk to them, figure out what do they understand of what's going on. I've
yeah.
had a lot of breast cancer patients being looked after by their 11-year-old child or their
Oh,
14-year-old.
wow.
They take up
Wow.
the role of the caregiver.
Mm,
And I had this man who had severe lung disease, and his son was excellent at choosing his medication and preparing his medication for him in a box, knowing and knew his medical admission history.
yeah.
Children know more than we give them credit for. They really have an idea of what's going on. It's just that we need an outlet to talk about it, and so we should be able to explore what it is that they
Yeah.
understand about it, and then if we need to elaborate further. But of course, being children, we can't use very sophisticated words, and we can't be
Yes.
too direct. So it's a form of being gentle, and it's a form of communication skills. um, we have a lot of workshops on dealing with these kind of scenarios.
Um, Support groups?
Well, it's mostly workshops by pediatric palliative care doctors
Oh, I
and the
see. Okay.
and hospices as well. Yeah, and if you look it up, you can probably get into one of these workshops. Give you a better idea than I can talk to you about over this short period of time.
Okay.
Yeah,
Okay. All right. I just want to say, well, I hope that answers your questions. We'll just, this is not actually a question, lah, but it's a good reminder. This is from Lily Lu Li Neo. Family support and love is the most important thing. Yes, definitely. Okay. Now we're going to go straight to the quiz. Yeah, we have to do the quiz now. Okay.
yeah.
And yes, but don't forget that you have to share the link at least 3 times in order for you to take part in the quiz, ladies and gentlemen. But what do you need to do to win? You got to make sure to share the video. Yes. Next, you answer the 3 questions that will be showing on the screen in a single comment, and then you're on your way to win the prizes. And the prize today is oximeter. Great. All right. Are you ready? Number one, only a doctor can give palliative care to a terminal patient. True or false? Only a doctor can give palliative care to a terminal patient. True or false? Okay. Second question. End of life care is similar to euthanasia. True or false? One more time. End of life care is similar to euthanasia. Euthanasia. Okay. Third question, at the end of one's life, one may experience constipation, nausea, and urinary retention. Is that true or false? At the end of one's life, one may experience constipation, nausea, and urinary retention. True or false? Don't forget, you've got to key in your answer in one posting, okay? One comment. All right, so while waiting to hear who the winners are, let's just get back into Doctor's slides. We don't have that many questions today. It's a very challenging topic because, okay, we've got a question that's asking how do family members deal um, emotionally with someone who is about to leave them. Do you have any tips on that, doctor?
I guess the best is communication, talking about it, seeking someone who you are comfortable to talk about it, and
Yeah.
expressing your sorrow, expressing your grief. That's important. Um, I know some of us doctors may look like robots and machines in front of you, but um, we're also a good source of a good shoulder to sort of cry on. And I sometimes I spend an extra time with family members at the bedside, listening to their concerns and their emotions in dealing with what's happening
Mm.
to their
Mm.
loved one. It's important to talk about it. That's how we deal with it. That's how we cope with it. There's many ranges. We need to acknowledge that the emotions that you feel is validated. It's
Mm.
right. Don't hide it. What
Yeah.
you feel is what it is,
Mm.
and talk about it. If you have and express what are your concerns about it. And if you find that these thoughts are just creeping up and
Mm.
it's not leaving you, and you're finding that you have
Mm.
difficult time forgetting them and functioning with them, then it's time
Mm.
to get professional help. Speaking to a counselor or a psychologist
Yeah.
who can help you, look at it and from a different point of angle, and give you a different perspective on how to deal with it. Things I know there's one very common or very useful method called cognitive behavioral therapy. Can
Mm.
help psychologists use can help people look at how they deal with their emotions and how they think about
Yeah.
passing of a loved one and how that
Right.
grief has affected them. Yeah,
Yeah.
so there are ways of doing this, and I think it's all about communication. Yeah.
Okay. All right. Oh, I see. No wonder there's actually a lot more questions, but it is not shown here. I have some here. Do you mind if we take a few more questions? Okay, there's
Sure,
one
go
here that
ahead.
says,
Okay.
my grandfather is, sorry about that, ladies and gentlemen. I didn't realize. I was wondering how come not that many questions, but actually we do have some here. Okay, very quickly. Hopefully by 4:30 we can wrap this up. My grandfather is 70 plus, currently intubated for severe COPD. We were informed that the lungs are very bad. Hope his condition improves. My question ideally is when to be ready for end of life care, and what are our roles to support? Okay, good question.
Mhm.
What would you
Now, if your
say?
grandfather is receiving is on life support at this time of time, um, we need to look at what the doctors think his chances are. Now, if he comes out of it, and I hope he does come out of this, then it's time to talk about the next step, because COPD is a continuous declining disease, and your grandfather may be at a early stage of COPD, or he could be at a later stage, and that needs to be defined clearly by your respiratory physician or your physicians looking after. And you need to get some idea of the prognosis, not just about how is he going to do now, but what's going to happen to him in the long term. What are the expected complications? This is where we talk about advanced care planning, getting a
Yeah.
plan, planning for the worst while hoping for the best. And so uh, I think speaking to your doctor about what's happening, what's going to happen to him now, and would he be able to pull out of this? And once he does come out of this, then speaking to your respiratory physician about what's going to happen in the coming days, in the coming years, where is he headed, and what we should do. And from
Yeah.
that, it gives you a guide to planning the end of life care for him. and looking at your preferences and looking at the goals of care your grandfather wants for himself. If he can't do that, then someone should help, choose or make those decisions for him. Preferably someone who knows him best, who knows what his values
Yeah.
are, and how he would want treatment, what kind of treatment he would not want on himself. So
Yeah.
it should go. We should start off with finding out what's to expect, what's to come. You know, yeah.
Yeah. Well, I'm going to throw in two more questions here from Lady D. Anafiros. Is there any guidelines on how to give end of life care? Maybe we can just zoom in on the very main guidelines that
Well,
everybody should.
short answer. Short answer
Sure.
is yes. If you, I mean, it's amazing. YouTube is an amazing tool. So if you head on down to YouTube, you'll find a lot of topics, especially from the US and the UK, on videos talking about end of life care. But home at the local scene, Hospice Malaysia has come up with a list of videos on palliative care, including end of life care. If you go to
Yeah.
the Malaysian Hospice Council, they have a section on caregivers. There's a link, resources for caregivers, and you can click on that. It'll take you to a document, and just below that is a video on performing physiotherapy at home.
Oh, okay.
So we've got tons of resources and guidelines for end of life care. Some may appear to be very technical because they're meant for doctors and specialists like me, but there are a lot more which are very simple, patient-centered, caregiver-centered guidelines. We're not stingy. We're not keeping this information to ourselves. We want everybody to be in good and palliative care as much as we are,
Yeah.
as much as you are capable of doing, and we're here to support you. So
Yeah.
yeah, resources are out there. It's just a matter of typing in palliative care, end of life care. It'll just jump to you on the screen.
Okay, that's great. That's good to know, doctor. Thank you. All right. Last question. Actually, there are two questions. Okay. Sorry. I've been wondering. Sorry. Also from Lady D. I've been wondering. My grandfather is intubated now. Will he be able to feel or hear our presence?
Yes, I think you should just go with that and talk to him, um, touch him, let him know you're there, let him know
Yeah.
that he's not abandoned. Um, I mean, sedation can knock someone out, but you really don't know. We've heard of cases where people have gone through general anesthesia and were fully awake during their surgeries. So you just don't know for sure. I like to think that
Yeah.
they're awake, because if there can be brain activity at the end of life, there can be during sedation.
Of
So
course.
talk to him and talk to them, and let them know they're there. Give them the encouragement. Family is really the best medicine for a person facing the end of life.
Yeah. Agree. Okay, Doc, we're gonna have to address the quiz questions because we've got our winners already. Please, Doc, you can do the honors of letting us all know whether which answer is true or false. Only a doctor can give palliative care to a terminal patient. True or
Uh,
false?
the answer, the answer is false. I've already just said it.
Yeah.
Anybody can give palliative care
Yeah.
based on their capability and their, what they're able to do. It's
Yeah.
just a matter of learning it.
Okay, so the next one is end of life care is similar to euthanasia. Is that true or false?
Absolutely false. No,
All right. And
definitely not.
yeah, we addressed
So
that
the
already.
answer
That's
is
right.
euthanasia.
And the last one, at the end of one's life, one may experience constipation, nausea, and urinary retention. True or false?
And that's true. There are multiple symptoms at the end of life, and we have to be prepared and anticipate to manage all these.
Okay, and with that, we shall announce our three winners. Number one is Lady D. Anna Fairos. Number two is Lily Lu Linio. And number three is Zura Azu. So congratulations, all winners. You've won yourself an oximeter. And I'm sure that everyone has found this talk particularly useful. It's very poignant topic actually, Doctor. And I'm sure all who have tuned in today have experiences, either they have had experiences or are experiencing taking care of a loved one, and it must be very hard on all of you So wish you all the best. And anything else that you would like to tell them, Dr. Navin?
Well, I'm very I feel privileged to be able to present and talk about this topic. It's very dear to my heart. It's a real reason I joined Palliative Care, to ensure that people die in comfort. And I feel honored to be able to talk to everybody about this.
Yeah,
Um, I have a lot more to talk about. What we've just discussed is
yeah,
the tip of the iceberg,
yeah,
and it's a whole lot. It's a whole big iceberg. So if you really want to speak to me, and if you want to get to learn more, I'm happy to to do a longer webinar or a longer talk, and or sit down with you at a coffee shop, and we can discuss this in length and in
yeah.
detail.
I really think that we need a part two to this because there's so much to discuss, and it's really, really helpful, because it's very difficult going through this, and there are not that many experts that we can ask when it comes to palliative care. I'm assuming, but in the Columbia Asia group, you are the only one right
Yes,
now. So
currently.
thank you for that, and thank you for making time, Doctor.
Yes, welcome. I'm happy to be here.
Thank you. And everyone, we'll see you again in the next episode. Thank you for being with us. Doctors Go Live signing up now. Bye.
Well, that's it.